Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the South West Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a haemareg.
And let's get started on today's topic.
From basics
to brilliance. Okay, hi David, how are you?
Good, thank you, Harry. Ready to crack on with some more CNS lymphoma action?
Excellent. Okay, so today the topic we're talking about is secondary CNS or central nervous system lymphoma. So I would just say a little note to our listeners that if you haven't already listened to the primary CNS lymphoma podcast episode, then I recommend you head over and listen to that first, because we cover in a little bit more detail and a bit more depth the investigations and workup of CNS lymphoma in general in more detail. And also, if you're like anything like me, it's quite easy to get confused between primary and secondary CNS lymphoma, and actually they're quite different in terms of how they're managed and the evidence base behind them. So it would be a really good idea to listen to the primary CNS lymphoma episode first, and then listen to the secondary CNS lymphoma episode that we're going to talk about today, so that you can compare and contrast and get them really cemented in your head as different. But so today the focus is secondary CNS lymphoma. Does that sound okay, David?
Yes, good. And our primary CNS lymphoma is a very good episode, if I do say so myself.
A cheeky plug there, very good. Right, so David, what is secondary CNS lymphoma? What do I mean by that term?
From what I understand, it's a lymphoma that it originated in the body and then has gone to the brain as opposed to started in the brain.
Yeah, absolutely. So it's lymphoma that's originated in the body and gone to the brain. And we divide it into three different kinds of secondary CNS lymphoma. So the first kind is called treatment-naïve. And treatment-naïve is where it's presented in the brain and the body at the same time. So these are patients that have yet to have been exposed to any sort of chemotherapy or treatment. And at the time that they turned up with a lymph node under their arm, they also had neurological symptoms and were found to have CNS disease at the same time. So we call them treatment-naïve, or abbreviated to TN. Then the second kind you've got is relapsed, where it's called relapse isolated. So this is where you've had previous diffuse large B-cell lymphoma, let's say a node under your arm, and then you had treatment for that, and then sadly down the line you then relapse just in the brain. And so there's nothing in the body, it's just in the brain, and that's called relapse isolated, or RI. And then you've got the third kind of secondary CNS lymphoma, which is relapsed concomitant. And this is where you have relapsed both in the brain and the body at the same time. So this is where you start off with your original DLBCL, let's say, again, a node under the arm. You have your treatment for it, you're in remission, and then unfortunately you relapse, and at the time of relapse, it's in the brain and the body at the same time. And that's relapse concomitant, or RC. And the reason why I divide it into those three is you'll see that terminology used a lot in guidelines, like the BSH guidelines, and also a lot of secondary CNS lymphoma is referred to in these terms in things like research trials as well. So it's just useful to get that terminology in your head early on. So
I noticed you mentioned the diffuse large B again, and in primary we were saying that the vast majority of the primary lymphomas were diffuse large B. Is it the case that secondary lymphomas tend to be diffuse large B as well, or is there a bit more variety? Okay.
No, that's right. It's generally high grade disease.
Okay.
So what do you think are going to be the investigations that we need to do in somebody who's got secondary CNS lymphoma, David?
So I guess we've been talking about sort of focal neurology. So I definitely like to have a MRI of the head.
Yeah.
And then probably a PET CT scan to see, you know, where these concomitant sort of lymphomas are coming from.
Yeah, absolutely. So just like with primary CNS lymphoma, you're going to want to get some really good imaging of the brain, and that's going to be MRI with gadolinium contrast enhancement. And you're also going to want to get a PET scan of the body to look for involvement of disease elsewhere in the body. Do you remember anything else that we did to sort of stage lymphoma? Because what we want to do here in secondary CNS lymphoma is work out, for example, if it's relapsed, whether it's relapse concomitant or whether it's relapse isolated. So whether there's just disease in the brain or whether we're dealing with brain and body disease at the same time, because that will make a difference to treatment.
I know in the primary one we talked, not at length, but we kept coming back to sort of checking testicles as well as the eye exam as well, the slit lamp. Is that what we're sort of talking about here?
Exactly. So you're going to get a testicular ultrasound scan. And you're also, because we know that PET scans aren't sensitive enough to pick up disease within the testicle. And you're also going to get a slit lamp exam to make sure that there's no disease in the back of the eye. And that's because the eye and the testicle are two other immunoprivileged sites along with the brain. So yes, we're going to do that. And what about biopsy? What are you going to do what are you going to biopsy in secondary CNS lymphoma?
So I suppose we'd want to get a biopsy of the brain. And I know we talked about the difficulty previously, and you know, when it's inaccessible or part of the elegant part of your brain, and you didn't want to do more damage than good by getting a diagnosis. But I suppose if you have more accessible lymph nodes, say like the ones under your arm, and it's sort of come up at the same time, I would imagine that that's probably effective enough to get a diagnosis, and then assume, I don't know if that's the right word, that the CNS lymphoma is the same.
Yeah, absolutely. I think that's a really good point. I think in primary CNS lymphoma, there's a massive focus on needing to get a brain biopsy. And we talked all about the perils of patients having steroids before they have a biopsy of the brain, and the brain biopsy therefore being non-diagnostic, and the difficulty that can pose. And we talked about the difficulty, as you said, about getting a biopsy of the brain when it's in the brainstem or somewhere quite inaccessible. And I think in primary CNS lymphoma, the thing is there's no other tissue that you can get in the body, and there's nowhere else easily accessible. And actually, therefore, there's no clue that this is actually lymphoma in the brain in primary CNS lymphoma, other than what the imaging suggests. And obviously, we did talk about those quite rare cases where we have to go on just the imaging appearances, plus maybe the CSF flow showing malignant B cells, and the rearrangement of the immunoglobulin gene on PCR from the CSF as ways to make a diagnosis in very rare cases where truly the brain lesion is not biopsyable. But in the vast majority of primary CNS lymphoma, you really do need to get a tissue biopsy of the brain, because otherwise there's nothing to distinguish it from metastatic breast cancer or a glioblastoma or some sort of primary CNS cancer of some other kind. But when you're looking at secondary CNS lymphoma, either this patient has already had lymphoma in the body in the past and they've got an isolated relapse in the brain, which if it's in the context of a couple of years from treatment of their primary diffuse large B-cell lymphoma in the body, then it's reasonable to assume that probably is relapse lymphoma. And if it's relapse concomitant, then you're just going to biopsy the thing in the body, as you said, because it's way more accessible, and then assume that that's the same disease process, because that's the most likely thing. I think the situation in which secondary CNS lymphoma is more important to get a primary diagnosis can sometimes be in treatment-naïve, where you've got body disease, but you're not necessarily 100% sure that the brain lesion represents the same disease. But overall, the pressure is less to get a brain biopsy. And so if you get a lumbar puncture, for example, which shows CSF flow showing high-grade B cells, then actually that can be sufficient. So yes, I agree. Ideally, we want to get a brain biopsy, but we can often kind of infer if the imaging looks very consistent with lymphoma in the brain, that it is the same disease. I guess the caveat to that is if you had diffuse large B-cell lymphoma like 10 years ago, and then you're getting a brain lesion, that's a lot more suspect, because you would have expected the DLBCL to have relapsed by then, so then that could genuinely be something else. But yeah, if it's within a couple of years of the primary diagnosis, then you can just re-biopsy the body disease instead. Good. Okay. Yeah, I'm glad we talked about that. So let's talk about treatment of secondary CNS lymphoma. So when we talked about primary CNS lymphoma treatment, we went through the different trial evidence. And that was important because that allows you to then understand what the evidence is that leads to the management decisions that we make. Have you heard of any trials in secondary CNS lymphoma at all, David? And what do you think is going to be, I guess, the additional challenge of treating secondary CNS lymphoma compared to primary CNS lymphoma?
Okay, no trials. I've got nothing on that regard.
That's
I imagine that the challenges, though, are similar to what we were presented with primary, in that it still has to cross the blood-brain barrier. And while I would be quite happy to give like an R-polar chip for a diffuse large B-cell lymphoma in the body, I have no idea if that gets into the brain. And I have no idea how effective our matrix kind of chemotherapies would be on a systemic kind of lymphoma.
Yeah.
So yeah, that's where my head's at.
Absolutely. You've hit the nail on the head. So the challenge of secondary CNS lymphoma is you've got disease in the body and you've got disease in the brain. And as you say, the chemo that you would choose to treat brain disease is chemo that's in high doses, high dose intensities, like we talked about last time, with matrix chemotherapy, and is specifically chemo that crosses the blood-brain barrier. So thiatepa, methotrexate, and cytarabine, which are not the chemotherapies that we classically use on the ward for all of our DLBCLs, in which you've mentioned R-polar chip, which is, first line now for good performance status patients with diffuse large B-cell lymphoma with a high stage. So yes, you're right. So what do we do? So the other issue with treating secondary CNS lymphoma is that, unlike primary CNS lymphoma, where we had some really good randomized control trials, which have really informed our treatment, particularly the IE-LSG32 trial, if you remember, which randomized both different types of induction chemo and then also randomized different consolidation methods, so whole brain radiotherapy versus a thiatepa carmustine autologous stem cell transplant. There isn't the same equivalent trial in secondary CNS lymphoma. It's just a single-arm phase 2 study called the Marietta study, or also known as the IE-LSG 42 rather than 30.
There's that name again with a number after it. Yeah,
exactly. So, but this is a key trial, the Marietta trial, and you will hear it as referred to as the Marietta protocol, which is why I wondered if you had heard of any trials in secondary CNS lymphoma. And basically, it was a single-arm prospective trial in which they alternate between methotrexate and RI-SCNSL. So it's three matrix, alternating with 3 RI-SCNSL. And this then, after you've done that as your induction, you then take the patient to an autologous stem cell transplant. Okay. And this is the main trial. It's the largest prospective trial in secondary CNS lymphoma. It involved 75 patients, so not huge numbers, to be honest. And it was for fit patients, so a performance status of less than or equal to 3, in which, again, remember, performance status is, again, about pre-morbid performance status, like we talked about with primary CNS lymphoma. They might not look that fit at the beginning, so a steroid pre-phase to try and see if that peps them up a bit can be helpful. But then also just bear in mind that if pre-morbidly they had a really good performance status a couple of weeks ago, then that's what you should be going off, rather than what's directly in front of you, given that they've got a CNS disease. And yeah, so the matrix is basically used to cross the blood-brain barrier and treat the brain disease. And then the RI-SCNSL is quite a good salvage chemotherapy that we would use for relapse refractory diffuse large B-cell lymphoma normally. And then anyone who achieved a partial response or a complete response, as I said, was then consolidated with a carmustine thiotepa, so a CNS penetrating autologous stem cell transplant. Okay. And the 2-year overall survival for all of those patients included in the trial was just under 50%. So not amazing, certainly not great compared to, do you remember what the sort of figures were with matrix and an auto for a primary CNS lymphoma, David?
I'm racking my brains and hold on, wasn't that the region of 70%?
Yeah, exactly.
Yeah.
70% achieved a 7-year progression-free survival. So
I remember us saying that if you got through the first couple of years, the chances were you were looking good.
Yeah, exactly. So this is unfortunately not as good, with a 2-year overall survival of less than 50%. And the important thing about the Marietta study is that it gives us information, like prognostic information, on the 3 different groups. So the first group, the treatment-naïve group, they're the ones that have presented with brain and body disease first line and have never had any chemotherapy before. They did the best on the Marietta study, and they had a progression-free survival at 2 years of 70%, so actually not bad. And again, they recommend dropping one of the cytarabines in the matrix in the protocol if they've got a bit of a dodgy performance status, or if they get neutropenic sepsis with the first cycle. And just like we did with primary CNS disease. And if they're frailer or older, though, then we would use the Martyr approach again, like we did in primary CNS lymphoma, alternating with the systemic treatment RI-SCNSL. Do you know what RI-SCNSL is? I just realised we haven't really talked about what that contains.
I imagine the R is rituximab.
Yeah, that's right.
And the C could be any one of the cyclophosphamide or cytarabine or whatever the C's they get in there. I don't know.
It's actually carboplatin, unfortunately.
Oh, that's
sorry. So it's isophosphamide. It's ifosfamide, carboplatin, and etoposide. That combination of chemotherapy, in which ifosfamide can be quite neurotoxic actually, and cause quite a lot of encephalopathy. Carboplatin, so platinum-based chemo, can cause quite a lot of peripheral neuropathy, as can etoposide. So it's quite punchy chemotherapy. But anyway, so those patients, the treatment-naive ones, did the best. The ones that did the worst, who do you think would do the worst with the Marietta protocol or with treatment of their secondary CNS lymphoma?
So I suppose, the relapses who have come in with it everywhere. So would that be the relapse concomitant? So it's all over their body and in their head.
Exactly. And they had a dismal outcome of 14% 2-year progression-free survival. Yeah, I know. And despite an initial response rate of almost 50%, many didn't make it to an autologous stem cell transplant, mainly due to the toxicity burden of the induction. Because, you're alternating matrix, which we already know is quite intensive, with RI-SCNSL, which is quite intensive as well. And their performance status is often quite poor because of having disease everywhere. So they did the worst. And then in the middle somewhere are your relapse isolated patients, which have about a 40% 2-year progression-free survival, being treated by the Marietta protocol. That is basically how you would treat it. So basically you alternate between matrix and RI-SCNSL with an autologous stem cell transplant afterwards. And if they're less fit, then you might want to downgrade the matrix to the Martyr approach, which was methotrexate and cytarabine, but without the thiotepa, if you remember, and then go to an auto and aim to still auto them with your dose reduced thiotepa as required. And then I guess the only other thing to say is with relapse isolated disease, secondary CNS lymphoma, you don't necessarily have to treat with the Marietta protocol. You could just treat with matrix. So obviously they were treated with the Marietta protocol in that trial, but actually if you've just got brain disease and you're quite sure of that on the PET scan, ultrasound of the testes and eye exam, then actually you could just treat with just your matrix chemotherapy. Okay, so that's how we treat with the Marietta protocol, essentially alternating between body and brain treatment, 3 of each, and then an auto. What sort of follow-up do you think we need to do to assess response as we go along, David?
So I should think, like with, I guess, standard chemotherapy, where we do interval scans, we probably want to see if both the CNS lymphoma is responding and whether the body's responding. So I imagine in somewhere in the cycles, you'll want another MRI and likely a PET scan.
Yeah, so with the treatment-naive and the relapse concomitant patients, you're going to do a whole brain MRI plus or minus a spinal MRI if you've got disease there with contrast every 2 cycles. So you're going to do a matrix, an RI-SCNSL, and then you're going to do an MRI. And then you're also going to want to do a PET scan, as you said, to assess for the body disease responding. But we do that every 2 to 3 cycles just because we don't want the PET scan is more radiation, basically. So you're trying to limit it if you can, but obviously it's important that you know whether they're responding. I guess with the body, the beauty of body lymphoma is that you can also palpate a lot of disease a lot of the time to get a clinical idea as to whether somebody's responding or not. But certainly before they go for their auto, they're going to need a PET scan and an MRI scan to make sure they've got at least a partial response before going to auto. And then also you're going to do an end of treatment PET scan and contrast enhanced MRI. And remember, end of treatment PET scans are best done sort of 6 to 8 weeks after treatment so that you don't get a false negative. Because the chemotherapy shocks the cancer cells and therefore can make them not show up on a PET scan if you do it too soon after treatment. And then for relapse isolated disease, you're just going to need to image the brain plus or minus the spine with an MRI scan every 2 cycles. And you only really need to do systemic imaging like a PET scan if you've got some sort of clinical suspicion that they've progressed in the body. So yeah, so that's what your follow-up would be. Okay, what about if you have had your Marietta protocol treatment, you're less than 70, you've had your Marietta protocol treatment, you've had your auto, and then you relapse, let's say in the brain again. Where do we go next, David? Have you got any idea?
So I guess we're in Desperationsville here. If our numbers, we were saying that Marietta was sort of, sometimes as low as 14%. I guess if you're already relapsing, I imagine we are in CAR T and novel, what are they called?
Yeah, targeted
molecules. Yeah. The nibs and the mabs territory. Yeah.
Yes, exactly. So you're right. You could try and get a Bruton tyrosine kinase inhibitor. So because we know that they cross the blood-brain barrier, so that might be an option, but I don't know how you get your hands on it. Maybe through the drug company directly via a compassionate access scheme, or a trial is going to be the most useful thing probably to treat your patient. And then another option, as you say, is CAR T cell therapy. So do you know much about CAR T cell therapy?
I kind of understand the idea. You're effectively taking cells away, educating them to specifically target certain antigens, and then putting them back in the body so that they can go and do their business where your immune system has sort of failed to see these sort of foreign aberrant cells.
Yeah, that's a good way of describing it. So you're collecting someone's T cells, you're genetically engineering them so they've got a receptor against their malignant B cells. It will also bind to their normal B cells. And then you're reinfusing those T cells and they go to the disease and bind it and do cell-mediated cytotoxicity, because that's what T cells do. They're normally their job is to destroy like virally infected cells, for example. So they'll just bind and then destroy cells. And so in secondary CNS lymphoma, CAR T cells that are anti-CD19, which is obviously one of your B cell markers, can be useful, and probably is going to be a growing area, particularly within this group of secondary CNS lymphoma patients that we know are not doing very well. There were initial concerns, firstly, that the CAR T cells wouldn't cross the blood-brain barrier very effectively, which doesn't appear to be the case, and there has been, there is evidence that it does work. But also people were worried about neurotoxicity, and they thought that CAR T would produce higher rates of neurotoxicity when you had brain disease. And I guess the theory behind that is one of the big toxicities associated with CAR T is this thing called ICANS, where you basically get like a cytokine release syndrome, which can particularly affect the brain and can range from mild word finding difficulties on reinfusion of the CAR T cells to full-blown tonic-clonic seizures and a coma. And so people thought, well, if you've, and it's due to your CAR T cells binding to your disease and causing a big inflammatory response. And people were thinking, well, if you've got lots of brain disease and then these T cells go into your brain and cause loads of inflammation there at the site of your brain, then it may well lead to more neurotoxicity. However, the Zuma-7 study hasn't really shown that. So that's reassuring. So the CAR T cell is the axi-cell, also known as Yescarta, and that's been approved for the treatment of diffuse large B-cell lymphoma that relapses within 12 months, and or in primary refractory disease that hasn't responded. And so that might be something that you could access and refer your patients for. Sometimes, though, the issue, and we'll talk about this more when we talk about conditions like mantle cell lymphoma, in which CAR T cell therapy is being used a lot in. But one of the issues is getting patients to CAR T and being able to hold them whilst the CAR T cells are being made. But probably that would be your best bet, would be to refer these patients to a CAR T cell centre. But outcomes are bad, and I guess something else that's worth saying is, in a lot of these patients where we've been looking particularly at the relapsed concomitant patients, don't forget about palliative care. Don't forget about having an honest conversation with your patients about their 2-year progression-free survival. Don't shy away from those quite grim conversations that do need to be had with the patient, so that they know, so that they can get their affairs in order, and they can have realistic expectations of what treatment might achieve for them, because some people may choose to actually make the most of the quality of life that they've got left, rather than even go down the Marietta treatment in the first place.
Yeah, really valid point. I guess that's one of those things you need to keep in the back of your head. You know, I know that we are doctors and we like to treat and we like to fix, but actually, yeah, if it's not in keeping with your patient's goals, then yeah. Exactly.
And let's just talk about some other high-grade lymphoma immunoprivileged sites before we finish today's discussion. So what about primary intraocular lymphoma, David? Do you know how you would treat that?
This is so niche. I've got absolutely nothing in this regard.
Yeah, fair enough. You would treat it like that of a primary CNS lymphoma, so matrix. So make sure you stage them appropriately. So again, PET scan, MRI scan of the head, and ultrasound of the testes. But if it is just within the eye, then you're going to need to give some sort of systemic high-dose methotrexate-based combination chemotherapy regime with rituximab, such as matrix, or if they're frailer, Marta or Premain, like the primary CNS lymphoma stuff we talked about. And again, you would consolidate with an autologous stem cell transplant, even though that might seem a bit kind of heavy-handed for just eye disease. But that's what is recommended. And obviously, if there's any residual disease, then you can also consider ocular radiotherapy. honestly, I've never seen anyone who's had ocular radiotherapy before. I imagine it's not good for your sight, so that probably isn't something you want to do unless you have to. So therefore, systemic chemo plus autologous stem cell transplant is the way to go. If they're frail, then apparently you can do intravitreal methotrexate. I have no idea how you would do that.
Who do you even phone for that? I don't know.
I suggest that's some sort of niche MDT with ophthalmology. But that would be for patients that are really very unfit for any systemic therapy. So those are those patients. And then where's the other immunoprivileged site?
So I was going to say, we can't finish this without touching on testicles.
Yes, exactly. So in primary testicular lymphoma, one of the things to remember is that if one testicle is involved, then you've got a third of patients will have the other testicle involved as well. So don't forget about the other testicle is my message. So in terms of investigations, if you find a lump on a testy, you get an ultrasound scan classically, and this is, the GP or whoever's investigating this might be thinking about a germ cell tumor or some other, primary testicular cancer. And so the standard management is an orchidectomy of that side, even before you know whether it's lymphoma or not. So if there's a lump found on an ultrasound of the testy, you do an orchidectomy of that testy, so removal. And then the histopathology of that would show that it's a lymphoma. And at that point, you then want to get an MRI head and spine, because we know that if there's lymphoma in the testicle, then you need to think about the other immunoprivileged sites. You also want to do a lumbar puncture, okay, because actually a third of these patients will have CNS involvement, which is very high. So you're going to do a lumbar puncture as well as an MRI head and spine. LP is to look for protein, to look for CSF flow, CSF cytospin, and possibly PCR for the immunoglobulin gene rearrangement. And then you're going to want to stage it again, so with a PET scan of the whole body. And interestingly, also, they suggest that you should assess the skin for any signs of an associated cutaneous leg type diffuse large B-cell lymphoma. So I have seen this before, leg type DLBCL, and it's basically like a skin lesion of high-grade lymphoma. And that can be associated with the testicular involvement. So those would be your investigations. And do you know what the treatment would be for your primary testicular lymphoma?
So is it just sort of the similar stuff that you would do for diffuse large B? So some R-CHOP based basic chemotherapy?
Exactly. Yeah, so 6 cycles of R-CHOP or maybe R-Pola-CHIP. I don't know if you'd be eligible or not for primary testicular lymphoma or not. But certainly, a standard high-grade lymphoma chemotherapy plus CNS prophylaxis with high-dose methotrexate, which we'll talk about more when we talk about CNS prophylaxis and the controversial topic that it is in our discussion on diffuse large B-cell lymphoma more generally. And then also you need to not forget the other testy. So even if there's no evidence of it being affected, you need to do radiotherapy to the contralateral testy to reduce the risk of you relapsing in the other testy. Or I guess some patients might choose to just have the other testicle chopped off as well. Obviously, that would make you infertile. So that would be a sort of decision on a case-by-case basis discussion with the patient. But most patients would have about 30 grays of radiotherapy to the contralateral testy. So it's interesting because you would think in a way if you do an orchidectomy, you've removed the disease site. If there's no evidence of disease elsewhere, jobs are good. But actually that's not the case. You still need systemic chemotherapy, even when it's just stage 1 disease, because there probably is a bit of micro spread to like the para-aortic and iliac nodes and elsewhere. So they have done studies where they did radiotherapy just to the para-aortic and iliac nodes post-orchidectomy in stage 1 disease, and they weren't shown to be, that wasn't a successful way in reducing the risk of distant site relapse. So they very much do need systemic R-CHOP chemotherapy plus high-dose methotrexate prophylaxis, plus irradiation or removal of the other testes.
Grand. So despite us not ending on relapse and that sort of dismal kind of thought process, we have ended on removing both testicles. So yeah, fine way to end.
Removing one and irradiating the other, but yeah.
Okay. Maybe you can finish us on a slightly higher note with your 3 key takeaway messages.
So 3 key takeaway messages then. Number 1, secondary CNS lymphoma is lymphoma that has originated in the body and then spread to the brain. So whether that's treatment naive, where they present with brain and body disease at the same time as their first presentation, or whether it's relapse isolated or relapse concomitant, where they've had previous body disease and then a separate relapse in the brain, or brain and body at the same time. I would say, secondly, the main trial is the Marietta trial, also known as the IELSG 42. And this was alternating between treating the brain and treating the body. So matrix with RI-SCNSL, and then going on to have an autologous stem cell transplant, of which you do need to be quite fit. It's quite toxic chemo, both the RI-SCNSL and the matrix are. And only about 50% of patients in the Marietta protocol in the trial actually made it to the autologous stem cell transplant. And I would say that thirdly, it matters what type of secondary CNS lymphoma you have. So if you are one of the treatment naive patients, then your chances are quite good. But if you are a relapsed concomitant patient with secondary CNS lymphoma, your outlook is pretty bad. And you should bear that in mind for 2 reasons. If the patient's fit enough, you need to be thinking early about referral to a CAR T-cell centre. And if the patient's not very fit, then you need to be having honest conversations with the patient quite early on about where they are and what their disease means in terms of life expectancy.
Okay. Thank you for the nuggets.
Yeah, okay. So that's it. Any questions at all, David?
No, good.
Fantastic. Okay, well, I'll see you next time.
Until next time.
Thanks again for listening to Basics to Brilliance Haematology podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.